to show you, unfortunately, how similar all of these can present in patients. So there's some key things that you'll have to pick out on the differences on how these patients can present. A lot of these are older patients that are coming in, they've got abdominal discomfort, they've got bloating, maybe some weight loss, maybe some night sweats, all of the things that unfortunately are also associated with menopause. And so we've got to have a high index of suspicion if you're in a position that you're seeing older women. Some of you will not be in that position. When I looked at Bragg at the TMC, we saw all the way from 2 weeks all the way to 9 years old at the clinic there. So you may be in that position you're seeing that. So Air Force folks, do you guys see just active duty? Do you see dependents? Dependents too? So you guys don't see these patients. So we'll talk about this. Let's do a couple review questions. So you're performing a routine pelvic exam, and you see this on your exam. What do you want to do? You're going to do your PAP and then wait for the results. And depending on the results, refer for a colposcopy or biopsy. Refer, anybody not refer? I mean, this looks, there's something wrong. I mean, whether, you don't even have to know much about medicine to understand that this don't look right. You got something down here, discolored. You got something here, some lesion here. It's not a polyp, doesn't look like a polyp. Our polyps are red, they look like hemangiomas. Doesn't look like the Bothian cysts, and those are really the only two benign things that we talked about. So if you see something growing, you can do your PAP, you can send that off, but you should at the same time be doing a referral to OB/GYN and say, look, PAP results are pending, but there's an obvious lesion that does not appear to be normal. And it's up to them to say, nope, that looks fine to me, or for them to do the biopsy, because you're not going to be doing biopsies. Again, you can do a cervical scraping, but even if that cervical scraping is normal, it doesn't mean that this is normal. So it's best just to refer these patients not to only do the PAP and do nothing else. So follow up in a year. Those would all be things that we would do for a specific abnormal PAP. And then HPV testing, sure, we can do that, but it's not a follow-up. It's just somebody has an obvious lesion that we can address. And so you'll send those patients for a biopsy. So a 52-year-old female comes in, she's had a post-hysterectomy that was done because of uterine fibroids. She also has a history of CIM2 with a leak at age 34. Does she need cervical cytology? Yes, right? CIM2 or more, so that's CIM2, CIM3, carcinoma in situ, and cervical cancer. If any of those have occurred within the last 25 years, then they need additional evaluation for that 25 years. So we gotta go 25 years beyond the time. And think about this as not necessarily at the time of diagnosis, because I have seen patients that we have told them, hey, look, you've got some concerning results, you need follow-up, and they don't ever come back, right? So this is from the time of treatment. So once they're treated, then we start our 25 years, and we know that that these patients have result on longer treatment. So 34, we're assuming that leap was probably not only diagnostic, but also treated the CIN2. So 34, 44, 54, we've got to go to 59, right? So 25 years beyond the treatment method. So yes, she needs cervical cytology, and we can just do that with your co-testing. That's going to be the preferred method, at least for right now. So now you have a 34-year-old female. She comes in, and she says, I'm here for my well woman exam. My last one was 3 years ago. I think that I'm due. And when you review her results, she had a co-testing that was 3 years ago that was normal. What should we do for her? We repeat her, do a cervical cytology, should we do a co-testing? We don't have any idea what we're supposed to do. Should we do nothing? What should we do? You said 4, delta. We say nothing? We should do nothing? Come back when it's time for your co-testing, right? So that's the answer, right? Because she had co-testing, we don't have to do anything. And we have to educate, is what we have to do. Educate our patient. Oh, I'm glad to see you, so happy that you're here. But the good thing is you don't need another wound exam today because you had co-testing, those are good for 5 years. And we may have very well told the patient that last time we saw them. The patients don't remember things, so we have to write it down. And then when they come in, don't be frustrated. Say, no, we don't need to see you right now. We need to see you again in 2 years because you got a co-testing done. So someone said we could give them the option of doing a repeat co-test. Well, you can, but what's the point? There's really no point in it. If it was normal, don't do that because you're setting yourself up for having lots of other patients come back unnecessarily. It's our job to educate our patients. And not just because you're there, we're just going to do this for something to do. You've got a lot of other patients you're going to see that day. Educate your patients, tell them this doesn't need to be done. All right, so GYN cancers, really any cancer that begins in the reproductive organs. The 5 main types we'll talk about today: uterine cancer, also commonly known as endometrial cancer, ovarian cancer, cervical and vulvar and vaginal cancer. Of these, the only GYN cancer that can be prevented through screening, appropriate screening, is cervical cancer. And we know that HPV, the most common viral STI that we're going to see out there, most commonly causes cervical cancer, vulvar cancer, the majority of it, and vaginal cancer as well. So it's our job to just talk to our patients about HPV vaccination. 9 to 26 is preferred, and then those patients 27 to 45 if they're at higher risk. Let's start with uterine cancer or endometrial cancer. That's the most common cancer in developed countries. Second to cervical cancer in underdeveloped countries because they do not have the capability to do proper screening, proper treatment for cervical cancer. It does affect about 3% of the population, about 66,000 cases a year, with the majority of those patients being postmenopausal, so 60 to 70 years old. We do have up to a quarter of those patients, though, that can get endometrial cancer in their premenopausal period, usually due to chronic anovulation. So remember, chronic anovulation, we can see that with things like PCOS, but the problem there is we have persistent exposure to estrogen. We've got estrogen is thickening the lining of the endometrium. They're not going into that luteal phase, so they have this constant exposure to estrogen, and that increases their chance at a younger age of having endometrial cancer. This is really considered kind of an estrogen problem. There are a couple of different phenotypes. We have type 1 tumors, we have type 2 tumors. The majority of patients are going to come in with type 1 tumors. They're primarily adenocarcinoma. Okay? These patients, again, estrogen is the problem. It's estrogen-induced tumors, bless you. Most commonly, we'll see these in white females that are obese, that are nulliparous, meaning they have not been pregnant before, late menopause, early menarche. All of those things expose these patients to prolonged estrogen. Okay? The good thing is, even if it's diagnosed a little bit later stage, as long as it's metastasized or not significant metastasis, these guys tend to do pretty well with treatment. Usually, we get a clue that this is endometrial cancer because it has some precursor. And it's something like endometrial hyperplasia with atypia that we can see on an endometrial biopsy. These patients come in with abnormal uterine bleeding, send them for an endometrial biopsy. The endometrial biopsy has endometrial hyperplasia. They have a much higher risk of them progressing to endometrial carcinoma. So they treat these patients fairly aggressively if they identify them with endometrial hyperplasia. Type 2 tumors are a lot less frequent, so only about 10 to 20% of the population have type 2 tumors. These are not related to prolonged estrogen exposure, and the patients that comes in with type 2 tumors are completely opposite. These are thin patients. They have multifarious, so they've had lots of pregnancies. They typically tend to be African American. So again, this has to be on your radar for patients that are coming in, usually still with abnormal uterine bleeding. Unfortunately, if they have type 2 tumors, they have poor prognosis, and high mortality and morbidity rate. And again, not usually associated with estrogen, so we're not going to see that endometrial hyperplasia hyperplasia as a clue that these patients may ultimately develop endometrial cancer. And there are a lot of risk factors, but we want to think about this as a prolonged exposure to estrogen. Okay? So think about early menarche, late menopause, nulliparous. So nulliparous, think about that. These patients are not having any kids, right? So when we think, some people are like, well, yeah, but if they're nulliparous, if they get pregnant, we know that pregnancy is a high estrogen state, right? So you wouldn't think that that would be the problem, right? Instead of nulliparous, that the more pregnancies they have, they're exposed to more and more estrogen. But it's the cumulative amount of estrogen that we're talking about. So people that are nulliparous, they've never been pregnant, in their lifetime, okay, they're exposed to more estrogen. Even if someone has had 10 kids and they have a higher estrogen state during the pregnancy, but then immediately postpartum, they have a very low estrogen state for several months. Okay? So again, we think about this as nulliparous, even though we know with pregnancy they have a higher estrogen state. Anybody have any idea what might be protective against endometrial cancer? And it's not cocaine. Smoking is actually protective. Not to say we should encourage our patients to smoke by any means, but it stimulates hepatic metabolism of estrogen, smoking does. And so it ultimately decreases the incidence of endometrial abnormalities. I thought that was interesting in my research many years ago about this. So a majority of these patients are going to present to you with abnormal uterine bleeding. Okay? In those perimenopausal patients, we expect for them to have abnormal uterine bleeding. But oftentimes it's going to be lighter menstrual cycles that are occurring further and further apart. So be wary of these patients that are perimenopausal and they're coming in, I'm having heavier and heavier bleeding. Maybe still occurring farther apart, but instead of getting lighter, it's heavier. They may have pelvic pressure, they may have abdominal bloating, they have early satiety, meaning they get full earlier on. They may have abnormal cervical cytology, endometrial cells, atypical glandular cells. Okay? Remember, we talked about that yesterday. It's important that you know that. We may incidentally find some sort of abnormality on ultrasound because they came in with that abnormal uterine bleeding, or they had pelvic pain or pressure, or an ultrasound, and that ultrasound showed us an abnormality in endometrium. Maybe a CT scan was done because they had abdominal pain. Now that CT scan, they noticed something in the uterus. Remember, if you identify something abnormal in the adnexa or the uterus on CT scan, then ultimately you should go to the modality of choice, which would be a transvaginal ultrasound to further evaluate that abnormality. Okay. Sometimes these patients are undergoing a hysterectomy for another reason, and they identify it in the tissue on their hysterectomy. So anytime they take tissue out, they're going to send that for biopsy. Or maybe they had their appendix removed. And during having their appendix removed, they noticed some sort of abnormal lesion, maybe metastasis. So this can sometimes be found incidentally through our evaluation. Physical exam, oftentimes normal early on, and then in those late stages, we might find that the uterus is enlarged or it's fixed, and that would be abnormal. Labs, usually normal. So we usually can't rely on labs. CBC, chemistry, normal. Unless they have significant abnormal uterine bleeding, then we may see more of a chronic anemia on our lab. So unfortunately, physical exam and labs don't tend to lead us to believe this patient does or does not have endometrial cancer. Transvaginal ultrasound. So that's going to be our recommended radiologic study for these patients, usually again for the evaluation of abnormal uterine bleeding. Or if they're coming in with those other signs and symptoms, in a transvaginal ultrasound. Okay, for postmenopausal patients, we're looking at the thickness of that endometrial stripe. Greater than 4 millimeters is concerning. It is not diagnostic for endometrial cancer, but certainly concerning for endometrial hyperplasia. And so we're going to send those patients for an endometrial biopsy. For premenopausal patients, remember that the endometrial stripe can vary, can change in their thickness from throughout their menstrual cycle. So unfortunately, that's not going to be used as a diagnostic tool or a great screening tool. Doesn't mean we don't do it. We certainly do the transvaginal ultrasound, but just because they have a normal thickness of their endometrial stripe doesn't mean they don't have endometrial cancer. Any woman over the age of 45 that have abnormal bleeding, do the ultrasound, and then ultimately she should be referred to OBGYN for consideration for endometrial biopsy. If they're under the age of 45 and they have risk factors, those risk factors being prolonged exposure to estrogen, they've never had babies, they had menarche at 11 years old, they've been having some abnormal cycles. Okay? So those patients also get an ultrasound, but they should be referred to OBGYN. Gotta have a high index of suspicion for these patients. A diagnostic study of choice. Ultrasound is a screening tool. This diagnostic study of choice is going to be an endometrial biopsy. Okay? Not only for postmenopausal patients, but for premenopausal patients as well. Other options for diagnosis is using a DNC. So DNCs are done on patients that can't tolerate the endometrial biopsy, or if an endometrial biopsy was done, but it was non-diagnostic, okay, they'll do a DNC. So DNC, they'll go in and usually it's via hysteroscopy. So they'll take a scope, they'll look in through the external os, into the internal os, get all the way into the lining of the uterus, and they'll look for areas, and they'll take multiple biopsies, and they'll send that off. Okay. And then if these patients continue to have abnormal bleeding despite the endometrial biopsy being normal, then they will typically take them in and do a DNC using under hysteroscopy. Okay, CA-125, we've talked about CA-125 as a biomarker previously, and we know that it is not really specific. Even if it's elevated, it can be elevated in a normal person. So for CA-125, usually we're going to use this to help us trend. We'll trend this in patients that are undergoing treatment to see how well they're responding to the treatment. So yes, oftentimes this is done at the very beginning once the endometrial cancer is diagnosed with an abnormality, but we're using it more as this is what our initial level was and how is this patient responding to the treatment that we use CA-125 for. Chest x-ray can be done. That's really for us to identify metastasis. Same thing with CT abdomen pelvis. See, that may be done because the patient is complaining from abdominal pain, but for us, our purposes, it's not really used as a screening or a diagnostic tool. It's used for evaluating metastasis. And despite a 3% risk for these patients of getting endometrial cancer, there's no routine screening, there's no routine labs, or routine physical exam that is recommended to help prevent this. For postmenopausal patients, endometrial biopsy indications, abnormal uterine bleeding, okay? If they have endometrial cells or atypical glandular cells on that path, we want to refer them from endometrial biopsy. Or if they have a thickened endometrial stripe on ultrasound, refer them for biopsy. For perimenopausal patients, okay, if they're having intermenstrual bleeding, abnormal bleeding, uterine bleeding, or they have risk factors for high exposure to estrogen, those patients should also be referred for endometrial biopsy. Remember, when you're referring these patients for these biopsies, we're not really telling our consultants what to do. We're telling them the patient's signs and symptoms. And if they ultimately don't do the biopsy, and you still have significant concerns for this patient, then send them again. Have them see somebody else. We always do have a second opinion, even within the military system. And how do we treat these patients? We treat them with a hysterectomy. So total hysterectomy includes the uterus and the cervix, plus bilateral salpingo-oophorectomy. So they're going to take the ovaries and the fallopian tubes, and they're going to take some lymph nodes as well. They're going to, on all these cancers, they take lymph nodes because they want to make sure that they've got all the areas, and it helps them for staging and identifying, do these patients, in addition to surgery, do they need chemo, do they need radiation as part of the treatment modality. For patients that are premenopausal, okay, and they have not completed childbearing, they can do what's called fertility-sparing treatment. So they're still going to undergo endometrial biopsies. They'll do a diagnostic hysteroscopy. They'll do some sampling. so they know what their baseline is. And they have to be able to identify these patients, because just because somebody wants fertility sparing treatment doesn't mean they are good candidates for it. So they've got to identify, do they have deep invasion into the myometrium of these cells? Okay, do they have any sort of extrauterine disease? If so, these patients are not candidates for fertility sparing treatment. It's not recommended. So ultimately, if they identify they're candidates for fertility sparing treatments, type 1 tumors, they have adenocarcinoma, then they will put them on a progesterone. Usually nowadays, it's going to be a little levonorgestrel IUD. And the time period for them to be on that, it can be from 3 months to 3 years. Usually at least 12 months out. And the goal is to get them to complete resolution of the abnormal cells. So we're going to eradicate, at least for now, the endometrial cancer. Once they've done that, then they'll take them off the progesterone, they'll take the IUD out, and they'll allow them to try to conceive. Once they're done with childbearing, they put them back on the progesterone. So even if they have one child and they're waiting, they want to have another, and they can put them back on the progesterone in the interim, and then ultimately the plan is to put them back on the progesterone once they're done, and then until they can get that hysterectomy. But they will do this in patients that meet specific criteria. While they're on the progesterone, they're going to do some sort of biopsy every 3 months. Every 3 months, they have to have that biopsy to, again, identify if they're responding to that progesterone and see how well they're doing and what they need. For post-treatment surveillance, really is going to be evaluating these patients' signs and symptoms. We're trying to detect early reoccurrence for these patients. So most experts, there's not really a checklist that we go off, but most experts will agree that we're just going to monitor these patients. We're going to perform a routine physical exam, which should include a pelvic exam, a bimanual exam, and usually a rectovaginal exam as well. Every 3 to 6 months for the first 2 years, and then every 6 months annually thereafter. And CA-125 recommendations vary. Some literature says we should be doing it in the post-treatment period, and others say we should not. So usually that is not something that you guys are doing. By the time they're coming back to see you, they're usually beyond that first 2 years, and maybe you're just doing your exam once a year. What is not recommended is that we do pap smears on these patients with a specific plan of, oh, I should do this to identify if we have a reoccurrence. Right? We're not going to identify that in surplus cytology, right? So remember, the cervix is removed, the uterus is removed. So we're going to do vaginal cuff smears on these patients, and there just doesn't prove to be any benefit associated with that. Routine CT scans, routine chest x-rays, not recommended unless a patient is coming in with signs and symptoms. I was doing fine, but now I notice I'm having a little bleeding, or now I notice some abdominal pain and bloating. Now I'm having some night sweats that I didn't have. Then we might want to do these other studies. Otherwise, it's a physical exam, routine physical exam on these patients. All right, that is it for endometrial cancer. Let's go on to ovarian cancer. Ovarian cancer is the second most common cause of GYN cancer in the United States, and most common cause of GYN-related cancer deaths. Approximately 20,000 new cases a year with about 13,000 deaths. So high morbidity, high mortality associated with ovarian cancer. Diagnosis usually in the early 60s for these patients, and the majority of these cancers are going to be from the endoepithelial cells, so the outside lining of the ovary itself. Okay. The remainder of these are going to be germ cell or stromal tumors. And so germ cell, remember, is kind of coming from the egg. Stromal tumors is the area around the ovary. They have cord, they're going to have cord tumors. Those are going to be patients that are very, very young. So less than 20 years old for those patients that might be signs and symptoms. So again, for the young and the old, you've got to have a high index of suspicion for these patients. Unfortunately, despite the high morbidity mortality, there's no really effective screening tools that are recommended for women. And because of that, the majority of these patients are going to present at a much later stage in their diagnosis of cancer. So they're going to have these symptoms for months and months and months, before they finally present and say, look, I've been not feeling well for months, but I just thought it would go away. So again, the majority of these tumors are going to be epithelial, so it's because of the break in the outside lining of the uterus. Every month that someone ovulates, the outside lining of the uterus is going to break to release the egg, and every time that happens, you have a change in those cells, and that's the indication, or that's the causative agent for these epithelial carcinomas. The germ cell and the sex cord tumor is going to be inside the follicle itself. Okay. The risk factors that we see, so anybody that is ovulating more has an increased risk for ovarian cancer. So again, late menarche, early menopause, nulliparous people. If you don't have any pregnancies, you're ovulating the entire time. So those patients have more pregnancies, they ovulate less likely to get ovarian cancer. So nulliparous, early menarche, older age patients is typically what we're going to see. If someone has a family history of ovarian cancer, that increases their risk of ovarian cancer. A family history also of what? Breast cancer increases their risk of ovarian cancer. So think about that as well. There are some things that are protective for ovarian cancer. Okay, so patients, especially if they are BRCA positive, either family history or they themselves are BRCA positive, they would do a prophylactic bilateral self-lethal oophorectomy. They will prophylactically just take out the ovaries and the fallopian tubes out to prevent these patients from getting cancer resistant around the age of 40. Tubal ligation, okay, and hysterectomy. So tubal ligation, any idea why that might be protective? Yeah, so if we reduce the amount of irritants in the fallopian tubes, ultimately we reduce the amount of irritants that can get to the ovaries. So things like PID, okay, STIs, those cause irritation of the fallopian tubes, okay, which ultimately cause irritation of the ovaries. So if they do a tubal ligation, we reduce the chance of those irritants causing irritation of the ovaries themselves. Okay? Can't get to the ovaries. Of course, hysterectomy, okay, if you take out the uterus, uterus is a nidus for inflammation as well. Take that out, it reduces their chance of ovarian cancer. Breastfeeding, okay, patients are breastfeeding more, they're having a decreased ovulation, so breastfeeding is meant to be protective. And then oral contraceptives, even if someone uses oral contraceptives for 5 years, they can get up to 25 years of protection, okay? Or beyond their last use of oral contraceptives, and up to 50% decrease with not just oral contraceptives, but what other contraceptives?
I was actually going to ask, would that cover also like the brain patch?
The ones that do what? Decrease ovulation. So not IUD, right? Not the low-dose ID, not the copper ID, but anything that reduces ovulation, and that's their primary mechanism, then yes, you'll have that as well, the protection without. There's not been a lot of studies on those other combined oral contraceptives, hormonal contraceptives, but combined oral contraceptives, have been plenty of studies out there. But the thought is that anything that reduces ovulation is going to reduce their chance. And then parity. The more pregnancy these patients have, the less that they ovulate, and so these patients are going to be protected from that. There's one study that looked at endometrial ovarian cancer, and there was an 8% decrease per pregnancy. So again, we're not recommending patients have like 10 pregnancies so they have an 80% decrease, but certainly it's something to think about when they come in with risk factors. Look at their risk factors and look at their protective factors as well. So BRCA1, BRCA2, I think you guys have probably talked about this in other lectures, but the most common genes that seem to be associated with cancer, especially breast cancer and ovarian cancer. Now, when these work properly, they're protective. That's the whole point of them, is to be protective. Okay? They are tumor suppressing genes as long as they don't have a mutation. The problem is when they don't work properly, or when there's a BRCA1 or BRCA2 mutation. Okay? So now these patients have an increased chance of ovarian and breast cancer. So what they will do for these patients, if they are identified as having BRCA1, BRCA2, again, they will do a prophylactic bilateral self-lethal subhemophilectomy, usually recommended by the age of 40. Okay, and that's 90% effective in preventing epithelial ovarian cancer, and it also reduces or decreases the chance of these patients getting breast cancer. So that being said, who should get BRCA tested? Do we BRCA test everybody? Okay, we don't. Unfortunately, it's a very expensive test, and a lot of times the lab has to do pre-approval. One of my really good friends was diagnosed with breast cancer last year, and even though she was diagnosed with breast cancer, she has said, look, I've got an aunt that had breast cancer. She still couldn't get BRCA tested. She had to go out and pay for it on her own. Okay, so it's not something that we just routinely do, but there are reasons for us to do it. So if they have a history of ovarian cancer, they have breast cancer under the age of 45, family history of BRCA mutation, personal history of breast cancer, and at any age, and they have a male in their family that had breast cancer. So just kind of understand, because you guys may be in the position of ordering the BRCA testing for these patients. So I'm just trying to explain who should get it, and that we don't do it for everybody just because they want BRCA testing. The challenge really with ovarian cancer is that these patients are often asymptomatic, or actually often symptomatic for months. They're coming in with nondescript symptoms. So remember, these patients are older. So they're gonna come in saying, I'm fatigued, I have abdominal bloating, I have, increase in urinary frequency, and your urinalysis is normal. I have back pain. Well, everybody has back pain. Everybody's tired, right? So these patients may have come to see you a couple of times with these nondescript symptoms. You do some basic labs on them, they're normal. You do your analysis, that's normal. You do a physical exam, it's all normal. Okay, so what I want you to think about again for these patients is, what are their risk factors? So for these guys to come in with these kind of nondescript, so do you remember when you first started your menstrual cycle? When did you go through menopause? How many babies did you have? So start thinking through these other questions for these patients that are coming in, like, why do you keep coming in? If your patients keep coming in, you should say to yourself, what am I missing? What am I missing? I had a patient last week that came in the ER. This was his third visit for a headache. The headache was only on his right side. Only on his right side. And he was seen at the clinic, and they said, you've got a migraine headache. And they gave him some treatment for that, and it helped him. But then the next day, the headache was back, and he had this pressure in his eye that was associated with it. So then he went to the emergency department. The emergency department said, you have a migraine headache, and treated for a migraine headache. And it made him better. But now, 3 days later, he's back because it's better. It was better, but now it's back again. I just got this headache here. Do you have a history of migraine headaches? Well, I don't have a history of migraine. I get headaches every now and then, a couple times a year. I take ibuprofen, it goes away. Any vision changes? No, but you can tell he's super photosensitive, but really primarily in that right side. And so, what do? It's probably not a migraine because you don't have a history of migraines. Okay, why do we diagnose with people with migraines when they never even had a history of migraines, right? So this guy's, I don't know, 32 or something like that, 34. No history of migraines, don't think it's a migraine, right? So I immediately order what? A CT of his head, right? That's what it is. It's normal. CT of his head's normal. But something's not right. Why is this guy so photosensitive? So I said, we gotta do an eye exam. Let's check his pressures. He's 30-something pressures really good. Maybe he has a corneal abrasion that stained his eye. Stain was okay. Oh, so I said, something's not right. Now this kid does get seen quite a bit, but something's not right. So I called ophthalmology. And I called ophthalmology because I would go in and out of this room, and he's so photosensitive, and his eye just seemed red. And I take a little Q-tip, put on his eye, and I'm like, I think he has scleritis. I think that's the cause of him having this headache and this pressure in his eye. So I call ophthalmology and I say, look, I'll be honest with you. I've seen scleritis probably five times. And it's always been, I don't know, I'm not sure, because they don't have risk factors that I know of. This kid had really no risk factors. So ultimately, Oppo comes down, they see the guy, and they say, "Ah, he does have scleritis. Let's order these 5,000 labs on the guy to figure out why he has scleritis." So the guy happened to be, so they put him on intraocular steroids, and so we follow him up the next day, and he's doing a little bit better, and the guy has to go home on emergency leave for a few days. Well, his father, or I guess somebody in his family is a doctor, and they said, "You know what you need? You need oral steroids." So they put him on oral steroids. So he's got on intraocular steroids and oral steroids. So now when he comes back to see the ophthalmologist, he's got this vesicular rash all right here. So the oral steroids decreased his immune system. He was already on intraocular steroids, and now he's got shingles. And in his eye. So now he has a herpetic lesion in his eye, a dendritic lesion, what we call it, in his eye, because he went on the oral steroids. So ophthalmology says, come off the oral steroids because we told you not to take them in the first place, and go back on your, take your intraocular capsule. So again, the point of that whole story was, yay for me for figuring out what the hell was going on with this, but also, if they come back to see you, look and see what you're missing. Because they're coming back for a reason. Most of the patients that you're gonna see are like, oh man, I've seen you a million times for this, but you're gonna miss it when you have that attitude. So just think about what you're missing for these patients. These patients with ovarian cancer, very nondescript signs and symptoms. And unfortunately, physical exam doesn't help typically either, because we normally can't feel the ovaries on physical exam. If you feel a really large mass on physical exam, oftentimes it's actually not cancer. It's probably like a teratoma or something. But if you do, if it is cancerous, think about something that's fixed. Like, why can't I move this area of the adnexus? I should be able to move this around underneath my hand. Okay? Maybe if you have some sort of irregularity there, that's concerning as well. If you got an ultrasound on this patient, and maybe the ultrasound did show them they had ascites or CT, because these patients came with abdominal pain, you ordered a CT, and the CT shows ascites. Anytime you see ascites, that is very concerning. Pulmonary exam, probably going to be normal. If you did a chest x-ray, because these patients were complaining of upper abdominal pain, or maybe they were complaining of shortness of breath, and you see pleural effusion on chest x-ray, very, very concerning that these people have cancer. So anytime you see a pleural effusion or ascites, that is very concerning that these patients has cancer somewhere. Okay, so think that, keep that in mind. Okay. Most useful tests that we're going to use to help us in the evaluation for ovarian cancer is a transvaginal ultrasound. Okay. And so a transvaginal ultrasound, if there is a mass there, the radiologist and can give us words that are concerning, multiloculated, if they're, this is a solid, this is a septated mass, okay? There's neovascularization, it's nodular. Those are all concerning words that this is some sort of cancerous process. And again, a radiologist will tell us that. They'll specifically say, this is what it looks like, and it is concerning for something that is cancerous or is benign etiology. So they help us out in that aspect. CT abdomen pelvis, again, often not done in the initial evaluation, but it's done to look for metastasis. Do we have ovarian cancer and we have metastasis somewhere else in the body? And usually done for pre-surgical planning as well. Most of these patients are not going to go to surgery just from an ultrasound. Remember, ultrasound is not your diagnosis. They have to get tissue. Okay? So usually they'll do a CT abdomen pelvis as well, and then that helps them with staging before they go in for surgery. Again, CA-125, remember, can be elevated in benign and malignant ovarian tumors. If a patient gets a CA-125 level and they're on their menstrual cycle, it can be elevated. Teratoma, it can be elevated. So we're not going to use that to help us diagnose, is this cancer or is not. We're not going to tell our patients, you have ovarian cancer because they have an elevated CA-125. We can't do that. Okay, but it is helpful in following how this patient is responding to treatment. So it's going to be used to help us trend We'll trend this in patients' response to what their ongoing treatment is. So for referral, patients that are premenopausal, if they have an adnexal mass greater than 7 centimeters, they should be referred to OBGYN for a couple of reasons. One, we're concerned about the size, and it might be cancerous, but also we're concerned about the size, and it can cause ovarian torsion, right, or intermittent torsion for these patients. You gotta be careful. Any evidence of ascites, of course, any evidence of metastasis, you want to refer them. If they have a CA 2025 that you have to draw, it's greater than 200, that's really, really elevated. So that would be concerning, and that would be okay to refer these patients. Family history of one or more of their first-degree relatives that have ovarian cancer or breast cancer, those patients can be referred. You can still do an ultrasound in these patients. You can still do lab work, but really these are considerations for referral. Postmenopausal patients. Now we're talking about adnexal mass greater than 5 centimeters. CA 125 levels above normal. If they have ascites, and if they have a nodular or fixed ovarian mass, of course, there's metastasis, and then of course if they have that relative, then we want to refer those patients to OBGYN. Okay, how do we treat these patients? Surgery. So they typically do a total hysterectomy plus a DSO, bilateral sublingual oophorectomy. And then oftentimes these patients will need to go on chemotherapy. This is pretty aggressive treatment for these patients because very high morbidity, very high mortality associated with ovarian cancer. Post-treatment surveillance, physical exam, 2 to 4 months for the next 2 years. And then 4 to 6 months on that 3rd year, every 6 months, 4th and 5th year, and then annually thereafter. You don't need to know, don't spend time studying these post-treatment surveillances. I'm not going to require you to know that. Just understand that ultimately, probably at that 5-year mark, you guys are going to probably be seeing these patients for their annual exam. But don't memorize any of this stuff for the test. That's not something you're going to be monitoring initially. CT scans, PET scans, CA 125 recommended only if they have new signs and symptoms. That's not something we're doing. We're not routinely exposing these patients to additional radiation. If they have new signs and symptoms, then we're going to go off those new signs and symptoms and order additional imaging for these patients. Ultrasound is not going to be beneficial, right? Because they've had a total hysterectomy and DSO. So then we need a CT scan or PET scan. All right, cervical cancers. We talked about cervical cancer screening yesterday. Cervical cancer is the 3rd most common cause of GYN cancer in the United States, 1st most common in underdeveloped countries, again, because of screening. About 14,000 new cases a year, still a little over 4,000 deaths a year from cervical cancer. Oftentimes, we think about this as squamous cell carcinoma, usually from HPV 16, 18 serotype. Again, that prolonged exposure to HPV. Now, in underdeveloped countries, it's much more of a problem, like I said, 600,000 new cases annually, 340,000 deaths a year from cervical cancer. Usually, we're going to diagnose these patients a bit later because it takes about 10 to 20 years for cervical cancer to become cervical cancer. Lots of time in between that for us to help detect this and treat this before it actually becomes cervical cancer. Cervical cancer screening in conjunction with HPV vaccination. Ultimately, we should be able to catch this early on, and then hopefully in the next 5, 10 years or so, we can eradicate cervical cancer for these patients. So HPV, we already talked about this, most common STI. Most people in a lifetime will be affected with HPV. 75 to 80% of patients or people will have HPV. Doesn't mean 80% of patients are going to get cancer of one form or another. Not only can it cause cervical cancer, but vaginal and vulvar cancer as well, and then a lot of cancers in males. Ultimately, there's more than 150 different types of HPV, with about 40 different types that are going to affect the lower genital tract, and then 16 and 18 are going to be the main ones that we're concerned about for cervical cancer. That persistent HPV infection, that's what's going to cause our cervical cancer. We've got low-risk types of HPV, we've got high-risk types of HPV. Again, nothing you need to memorize here, just know 16 and 18. Those are the main ones that we're worried about associated with cervical cancer. And once we do our HPV swab, we send that off, if HPV is positive, that lab's gonna come back and tell us what subtype it is positive for. If it's positive for 16 and 18, we already kind of in our mind know that's highly oncogenic, and so those patients will typically be referred to a colposcopy. That's what's identified. We've got additional risk factors besides HPV though that we want to think about, right? Early onset of sexual activity means that they've probably been exposed to HPV earlier on, and then they have more likelihood of having prolonged exposure to HPV. 1.5 fold increase from cervical cancer for patients that are having intercourse 18 to 20 years old, earlier onset of intercourse. If they have multiple sexual partners, increased risk of cervical cancer. History of STIs, increased risk. Young age at the first time they had their first baby, so younger than 20 years old. And again, that probably, what they're thinking is these patients have a higher risk of exposure to HPV earlier on in life. Lower socioeconomic status, and that's usually limited because they have limited access to screening tools, so they have a prolonged exposure. And then cigarette smoking, both active and passive cigarette smoking, 2 to 3 times increase in those patients of developing low-risk squamous contractile liver, and then ultimately high-risk squamous contractile liver. We talked about prior pregnancies being protected in ovarian cancer, but here parity actually increases the risk of cervical cancer. Any idea why? Especially if I say vaginal delivery. Every time you deliver through that cervix, it's going to change the cells in the cervix. But even if you don't have vaginal delivery, the cervix still undergoes change in pregnancy. You have those changes, and that's going to increase your chance. So the more pregnancies they have, the more likely they are, unfortunately, to get cervical cancer. And then long-term oral contraceptives. Okay? So those that use combined oral contraceptives for more than 5 years is protective in ovarian cancer, but increased risk for cervical cancer. Okay? And it's really because they change the cervical mucus. Change the cervical mucus, because that's how the progesterone works, right? The progesterone works by changing the cervical mucus. So not only OCPs, but anything that has progesterone in it changes the cervical mucus, and it's that change in cervical mucus that increases the risk for cervical cancer. So this is why female reproductive cancer is so complicated. We can't tell our patients what to do. Smoke, don't smoke. Drink, don't drink. Take birth control, don't take birth control. Have babies, don't have babies, because they can have risk factors for those. Right? Because HPV is an STI, it's contracted through direct contact, using skin, mucous membranes, all the body fluids that have the HPV virus. Once someone has HPV, it's kind of held within a basal layer, and then over time, because it's held there, that's when we have the problems with the cancer. So we have that initial contact with HPV, and usually it's just kind of held in that basal layer. The body's immune system is going to ward it off, and you're going to push it out of the body. So normally we don't have any problems. In 90% of cases, this is going to be eradicated by the body. But the problem is that, about 0.8 or 10% of cases that we have that prolonged exposure. These patients typically don't have their routine screening, or they haven't done it in quite some time, not the 3 years or the 5 years. Now instead it's been 15 or 20 years. So when our patients come in for their ankle sprains or because they have an upper respiratory infection, we talk about not only HPV vaccine, but we also talk about routine screening. I see your last routine screening was this time. Let me remind you when your next routine screening should be. And I really say that more for the National Guard and Reserve, because in active duty military, they have to have their screening done as part of their metros. So National Guard Reserve, you're gonna be seeing patients outside of the National Guard Reserve duties, so those are the patients you want in mind. So how do we expect our patients to present? Oh, it's time for break. 3 years or 5 years, depending on what test they got. They may have irregular vaginal bleeding, they may have postcoital bleeding, they may have some abnormal discharge. They say, I don't normally have discharge, and I have this kind of leukorrhea, which is kind of a whitish discharge. And then sometimes these patients come in with this discharge, and like, okay, well, it really sounds like you probably have vaginitis, could be from bacteria, could be from yeast. So I think it is important for patients that come in, especially with new onset vaginal discharge, just have them do a self-swab. Have them do a self-swab. You don't necessarily have to do a pelvic exam after that, any other concerns, but to make sure that this is in fact vaginitis, so they have candidiasis or bacterial mastitis. If they have advanced disease, then again, they can have pelvic pain, they can have low back pain. They could come in with bowel and urinary symptoms because of the mass effect of the cancer itself. So just understand that a lot of times these patients be asymptomatic, and we're identifying this on the cervical cancer screening. Most HPV infections are going to resolve. We know that because patients are otherwise healthy. As long as they have good immune systems, this is going to go away. Except persistent HPV infection or that high-risk HPV infection with those high-risk strains, especially 16 and 18, that we'd be concerned about. Higher risk in patients that are older that have had this persistent infection. So we already know that we can prevent HPV by the vaccination. Other things that we can do to reduce the chance of someone getting HPV, if they have onset of intercourse later on in life, reduce the number of sexual partners they have. Of course, abstinence can help. Condom certainly can help, but a lot of times people do experience condom breaks, and anytime that occurs, they can get HPV. So current formula for HPV vaccination, the only have in the United States is the Gardasil 9. It's non-valent, and it covers 9 different subtypes of the HPV. It is thought to be what we call long-lasting protection. So really, HPV vaccination's only been around for the last 12 years or so. 12, I think about 12 to 13 years. So with any long-lasting, that's the information that we have. So the last 12 to 15 years is all the information that we have. But we already have seen a decrease in the number of HPV cases, decrease in cervical cancer. So the thought is that it's about 90-some% effective for the majority. Those high-risk types, maybe mid-80s effective. So although not 100%, nothing's 100%, certainly significant reduction in the number of HPV cases just from the several years that we've been using it. We do recommend it for all patients, 9 to 26-year-old males and females, and then 27 to 45 if they have a higher risk. Now, even with HPV vaccine, these patients still need to get screened. They still need to have their co-testing or their pap testing. HPV does not, the vaccine doesn't eradicate old infections, doesn't get rid of old infections. The body gets rid of old infections. HPV prevents new infections from occurring. Depending on when the person gets their HPV vaccine, will depend on if it needs to be a 2-shot series or a 3-shot series. Okay, so folks under the age of 15, we recommend a 2-shot series. If they're 15 and older, then we recommend a 3-shot series. And you will need to know that because you're going to be recommending these patients for their vaccine. And you got to tell them when they should come back. So 0 in between 6 and 12 months, they come back for a 2-shot, and then 0, 1 to 2 months, and then again at 6 months. There are contraindications to the vaccine. Of course, if they've had a previous reaction to the Gardasil vaccine, they shouldn't get a second dose. If they have a significant allergy to yeast, then there's a thought that either these patients shouldn't get the Gardasil 9 because they can't have a reaction to the medicine. If they have allergy to this dye, it's amorphous ammonium hydroxyphosphate. That's actually an additive to vaccines, and the polysodium A is a dye that they add to food. So most people have no idea that they're allergic to that, right? For the vaccine, maybe, if they say, oh yeah, I have a reaction to such and such vaccine, well now you've got to do homework and figure out, does that vaccine have this amorphous ammonium hydroxyphosphate in it? And if it does, you recommend that by itself. If they are sick, cough, congestion, they got a flu-like illness, it was recommended they wait until after they feel better to give the vaccine, and that's with most vaccines. And then pregnancy, not recommended to be given in pregnancy, but can certainly be given after pregnancy. Yes, each case of cervical cancer represents a missed opportunity for prevention, so talk to your patients about vaccination. What do we do if they have, in fact, cervical cancer? For pre-invasive, they can do cryosurgery. They can freeze those cells off. They can do laser surgery. We talked about LEAP. We talked about cold knife cone as well. If they have invasive cancer, so deep tissue involvement, they're going to do a hysterectomy, using a simple hysterectomy, which is removal of the uterus and the cervix. They can do a radical, which is cervix, the uterus. They can leave the ovaries if they want, but they usually do lymph node dissection. A lot of times nowadays, because of the age at which this is diagnosed, they would just remove the fallopian tube and ovaries as well. Maybe radiation, maybe chemo, depending on the extent of the disease. And then these pictures should look familiar. We've got that cold knife cone. Cold knife cone is done in the operating room. LEAP procedure is done in the clinic. We inject the cervix with lidocaine to numb it up, and then they'll use that wire, that heated wire, and they'll take off a layer of the tissue. As you can see that here. And then ultimately, these patients, the cervix tends to heal up pretty well. But imagine if they had to have multiple LEAP procedures, and then we talked about complications associated with that, like cervical incontinence is the most common thing that we see. All right, fourth most common GYN cancer is going to be vulvar cancer, and it represents about up to 6% of gynecologic reproductive cancers that we're going to see. 6,300 cases a year, and still about 1,600 deaths that are associated with vulvar cancer. Women have about 333% chance of getting vulvar cancer. So it's not something that you're going to see very often, but certainly in patients that come in with persistent pruritus, constant vulvar itching, if they have a new lesion, that kind of makes it easier for you. But what makes it really difficult is if they have this, I'm having this thin discharge, I'm having this constant itching. We talked about other things that cause itching. Atrophic vaginitis, lichen simplex chronicus, lichen sclerosis. So lichen sclerosis, we know, can lead to vulvar cancer. Okay? Other things, HPV. The average age of diagnosis for these patients is going to be in the late 60s. For African Americans, if they are diagnosed, it's often at a younger age, and these patients, by the time they present, are often at more advanced stages than we've seen for non-African American patients. Oftentimes, these guys are diagnosed kind of at stage 1 or 2, and more advanced stages are going to be seen in older women. So vulvar area, well, the vulvar area is this area in red. We've got the labia majora, the labia minora, the vestibule in there. We've got the Bartholin's glands in there, the periurethral glands, as well as Skene's glands, and then the vaginal opening. So that's the entire area that we want to look at every time we do our Roman exam, our Pap exam. We're going to look in that entire area to look for nodules, or feel for nodules, look for masses, look for any sort of hyperkeratotic lesions. The majority of these tumors are squamous cell, and they typically are going to arise from the vestibule, which is that area between the heart line and the hymen. And the second most common cause is going to be malignant melanoma. Okay, so malignant melanoma, these patients, just like with any other cases of melanoma, They typically have a very poor prognosis. In the bottom picture, that's a picture of malignant melanoma. So oftentimes, that is not their primary source. Most of these patients have had melanoma before, it was removed. And have you guys learned about melanoma in Durham yet? So what I remember from PA school about melanoma, in the very few cases I've seen, is they get an initial melanoma diagnosis, and it's a 10-year mark. If they can get beyond that 10-year mark, usually they do okay, but that 10-year mark is oftentimes when they have a reoccurrence of melanoma somewhere. And so patients that you're seeing that say, oh yeah, I have melanoma removed, always keep in mind, keep asking them if they had any lesions, even in their vaginal area. But ultimately, about a 5-year survival rate, about 50% of these patients will live beyond 5 years. And there are other less common causes that you don't need to spend time worrying about. But it could be verrucous. Verrucous is going to be wart-like carcinoma, less than 1%. It could be basal SAR. Could be a vulvar sarcoma. Those are usually nodular. Could be that Bartholin gland. We talked about that in patients, especially that come in, they're postmenopausal, they've got a new cyst in their Bartholin gland area, 4A position. That is always concerned. It could be Paget's disease as well. So most of these patients, if they're under the age of 55 and they get vulvar cancer, it's usually related to HPV and smoking. Okay? If they're over the age of 55, less likely to be related to HPV and smoking, more likely to be related to lichen sclerosis. So again, that chronic itching that they're having, those chronic changes in the vulvar area because of the itching. Okay? Now, if someone is smoking and has HPV, they have about a 35% increased risk of vulvar cancer. There are some studies that say that probably HSV occurrence also increases their risk of vulvar cancer, but there's other studies that say, I don't think so. But it makes sense, right? I mean, HSV, you've got changes in the skin that are associated with HSV, so especially patients that have chronic HSV occurrences, when they have recurrent outbreaks, kind of makes sense for those patients that have an increased risk of vulvar cancer. And then for patients that are chronically immunosuppressed, there's a potential link for that for earlier onset of vulvar cancer in those patients. These patients are typically going to present with a chronic pruritus. They're coming to you not because they necessarily have a lesion that they're concerned about, or maybe they do have a lesion and they're like, I don't know, but this itching is driving me crazy. Like, I'm always having this problem with itching. Maybe we'll get lucky and there'll be a visible lesion on physical exam. So this picture definitely has a visible lesion, but also there's something going on in this labia over here, right? So there's an enlargement here, and then we've got this visible lesion here as well. They may have pain, they may have inguinal lymphadenopathy, they may have bleeding that's associated with this as well. Oftentimes, these patients will have signs and symptoms, and even maybe a lesion for months before they come in to see you. They're embarrassed. Like, I don't know, like, this is so crazy. Like, why would I have this down there? Because most people don't even know that vaginal vulvar cancer are a thing. They completely know breast cancer, they know cervical cancer, they know ovarian cancer, they know uterine cancer, but they don't know vulvar and vaginal cancer. What? That's not even anything I've even heard of. Okay? So if there is a lesion, these lesions may be pigmented, especially if they're associated with melanoma. They may be raised, they may be ulcerated, they may even be warting in appearance, and may look like HPV on physical exam. Okay? But we don't always see a defined mass. Sometimes we'll just feel lymphadenopathy in a patient that has chronic pruritus. That's concerning. People shouldn't get lymphadenopathy just spontaneously. The goal really is for our evaluation is in our history for these patients, look at their risk factors, a physical exam. So you'll do your physical exam. If they have risk factors or they've had positive HPV, they are smoking, maybe they have inguinal lymphadenopathy, most of the time we're going to refer these patients for a vulvoscopy. So a vulvoscopy is, this big magnifying glass that they're going to use, and they're going to look at the vulva. They're going to use that acetic acid And they're gonna put on the vulvar area, and they're gonna look for any areas that will highlight in white, and then they'll biopsy those areas. Usually they'll do it with a punch biopsy. They won't take a big like elliptical area out. They'll do a punch biopsy of that tissue because that heals up really well. And then they'll send that off for evaluation. If they have any persistent lesions, and they'll biopsy that lesion as well, send that off for evaluation, and that helps them then in the planning stages for definitive treatment for these patients. Diagnosis for this is not physical exam. A lot of people have abnormal growths, they don't have cancer, it's histologic. It has to have a biopsy that is sent to the lab for evaluation. Okay, so I would not recommend that you tell your patients, I think this is vulvar cancer. Vulvar cancer is very, very rare. They can have a lot of other lesions that grow in their vulvar area that are not cancerous. They need a biopsy, and that needs to be sent off for further treatment. It's a histologic diagnosis. Treatment is pretty aggressive. Most often it includes like a radical deep tissue excision. Resection of the lymph nodes are often associated with this as well. And in addition to that, usually these patients will have to undergo radiation or chemo. Depending on the extent of the disease, they do radiation first, then they'll do the surgery, and then they do chemo after. Okay, so this is a person that came in that had vulvar cancer, that was diagnosed, again, histologically. They had a lesion, they underwent radiation first in this first picture. The second one, they had a partial vulvectomy. So you can see the remaining of the vulva is here and here, and then they essentially took off the bottom portion of the vulva and had a deep tissue resection as well. And then this is post-operatively when they went back to pull that tissue together. So again, for these patients, it's a pretty big deal once they're diagnosed. It's a pretty invasive surgery for these patients. And not only that, after the radiation, and typically chemo afterwards. So we want to make sure in patients that we're seeing that are older of age, they have the risk factors, they're coming in smoking, they have HPV, or a history of chronic itching, that we have a low suspicion for vulvar cancer, and we refer these patients for anyone that we're concerned about. Vaginal cancer, fifth most common cause, about 1 in 100,000 patients. Most cancers that are found in the vagina are actually not primary vaginal cancers. They're actually metastasis from other, typically reproductive cancer, from the ovarian cancer, endometrial cancer. Okay, of course, because most of these cancers are seen as patients age, vaginal cancer is associated with age as well. Typically over the age of 60. Certainly can be seen in younger patients, but usually we're going to see these patients in much older patients. So squamous cell is our primary cause for vaginal cancer in those older patients. If it's younger patients, it's going to be adenocarcinoma. And we talked about diethylstilbestrol. That was used like from the 40s to the 70s for patients after for supposedly pregnancy protection. But unfortunately, not only can the patient that had the diethylstilbestrol, but their offspring can also have cancers associated with diethylstilbestrol use. Usually these are going to be clear cell variants associated with that. So we've got to ask our patients if they had a history. Now, unfortunately, most of these younger patients are not even going to know if their mom had diethylstilbestrol in the utero when they were pregnant. So usually we're not going to get that history, initially at least. Ultimately, they're going to go back and get that from the parents. There are other, again, very rare causes of vaginal cancer, sarcomas, melanoma. You don't need to memorize these, but they are rhabdomyosarcoma. That can occur in very, very young kids. So if you're doing physical exams on young kids, or if the parents bring their patient in because the patient is complaining of pain, vaginal pain, that's unusual. So yes, we've got to think about other bad things, right, like sexual abuse, but usually you'll do a physical exam. If you see enlargement of the vulva, that's usually associated with rhabdomyosarcoma in these patients. We have liosarcoma as well. in these younger persons. And then melanoma can be seen in the vaginal area. Risk factors, HPV 16 and 18, just like we see with vulvar cancer and cervical cancer. Additional risk factors, multiple sexual partners, early age of first intercourse, if they're smoking, because all of those increase the risk of HPV and increase the risk of HPV penetration deep into the tissue. How do these patients present? Vaginal bleeding is going to be the most common. Usually it's going to be postcoital and then postmenopausal vaginal bleeding. They may have watery or bloody type discharge. They may have malodorous discharge. So we do that vaginitis panel, send it off for an STI panel as well. They may have a vaginal mass and have lymphadenopathy, dysuria or hematuria may occur, especially if that's mass in the anterior wall around the urethra can cause that. If it's in the posterior wall, these patients may come with constipation that is needed for them. Okay? 20% of these patients are asymptomatic, which means to me 80% aren't. Okay? That means that you've got to have an high index of suspicion. So if you miss it the first time, they come back a couple months later, it's your time to get it this time. Because 80% of these patients are going to have some sort of symptom. The key element for diagnosis is going to be the pelvic exam, vaginal cytology, and then ultimately a vaginal biopsy. Physical exam, the entire vaginal wall. When we put the speculum in, so especially if you're using metal speculum, which majority of you will not use, but that metal speculum, you can't see through it, okay? Even with the clear speculum, it kind of distorts you. So you're putting the speculum in, you've got to move that speculum all the way around, or better yet, oftentimes what we'll do is we'll take, the speculum comes apart, so you have a bottom part and a top part. Take the top part off. Go in only with the bottom part. That allows you to see the majority of the vaginal wall. Okay, and then move it up so you can see the bottom part of the vaginal wall. But you need to see the 360 of the vaginal wall. Bimanual exam. Doing a bimanual exam, we're not just necessarily checking for adnexal, we're checking, we're going to palpate the vaginal walls. Okay, all around 360 palpate the vaginal walls. Evaluate the groin area for lymphadenopathy as well. Cervical cytology in these patients, let's evaluate to make sure that see if they have HPV, because if they do, that also clues us in that maybe that's some sort of cancerous process. And then vaginal colposcopy, so they'll go in and they'll actually, we do a colposcopy of the cervix, they'll do tissue biopsies of the vaginal wall as well. Imaging, chest x-ray, skeletal x-ray, only if we're looking for metastasis. The same thing with CT, MRI, PET scan. If they're diagnosed with vaginal cancer, then they will do these to look for metastasis and help with surgical planning. Most patients again are not going for surgery just based on a biopsy. They're going to do some additional imaging before they do surgery. Okay, vaginal cancer diagnosed on histology, just like we see with vulvar cancer, usually not specifically from physical exam. So biopsy is going to be sent off, and that's going to tell us, is this cancer or not? And if so, then we look at our next steps for evaluating metastasis. Because it's rare, there's really no standard treatment that experts are doing on. But in general, they think about radiation, plus or minus chemo, and then some sort of surgery for these patients. They can, ultimately, they can remove the entire vaginal canal if they need to do that. It's a very, very invasive surgery if they need to do surgery on these patients. So we think about GYN malignancies, we think about 140,000 women a year, 34,000 deaths a year for these patients. With advancements in our treatment and our screening modalities, certainly have a higher rate of these patients surviving, but we have to be able to identify these abnormalities early on, these very subtle, often subtle signs and symptoms for these patients early on, so that we can identify the cancers early on. Alrighty, that's it. I think we're done for the week too, so we'll see you next week.
Bypass announcement. So first and foremost, we have talked So if you want tacos, find some of us down in front of Blessy Auditorium tomorrow morning from 7 to 7:55 selling tacos. So the funds we raise come back again to the student body. So like the coats, those are paid for with IPASS funds. So if you have other peers in like Bullock, Triple C, what have you, spread the word as well. One of the flyers is up here. You can take a photo and send it to them. But yeah, we'll have tacos out there. Two other things. So Operation Prom is still ongoing. We got 12 prom dresses and some heels already donated. So again, if you have any suits, dresses, we'll take those. April 5th, we are actually going to go out and help distribute those. So there's a small group of us that can go and help some of the high schoolers find dresses and suits that fit them that have been donated. So if that's something that interests you, come talk to me. I'll help you get signed up for that. And then last but not least, the food pantry. So April 5th, early in the morning, if you don't want to help with prom dresses, there are some of us that will be at the food pantry as well. So if you want to sign up for that and help serve some meals, come talk to me. I'll also help you get signed up. So thank you guys. Thanks for listening to my TED Talk. Have a good day. I'm going to go look at this play, but Big Ten, big time to go.
I don't remember her saying she was but close, so I don't know. She's like three different types of buses.
I thought they said that maybe that
Maybe I just don't.
but that would be
Yeah. She was a great goodbye type of person. A big goodbye type of person.
You actually think she's gonna yeah.
And I'm going to die for there.
Yeah, that's true. Any other rank. Yeah. Yeah, he was on the table. I think. I also like a house. Yeah, it's about like 4. Yeah, a lot better. That would make more sense. No, but I don't think it's the same thing, right? Literally, you're gonna have to just put up and like jack it off with like white coat. Like you said, anybody with anything CR officer within a year or two will be covered in a white coat. Yeah, so you're literally putting like put up. Just and yes, you are in those 10 seconds. So when I put the coat on and take my picture. So that's why we're just like now same but for some reason when I have a photo. Yeah, it depends on the site.
I don't know where it's at because it actually it makes it does look like I've always tried. I've seen some really pretty stars, but you know, unless you have like a special camera, you can't really cast stuff like that. When I was in the Albania house, like I saw some of the prettiest colors. There's like nothing here that are, but I couldn't really get it.
It's almost obvious.
Let's work together. This to give you a 77. I forgot about this. They want to see it. Well, yeah. I know.
I did.
He's not a white piece.
All right, are we ready? All right. So today is all of the viral stuff. There's a lot of pictures in here, and they are all beautiful, so you will love them. Okay. So yeah. So let's go. We're going to be talking about of the wards.